Hello and welcome to Frontier Nursing University's premier Digital Summit 2015. Our presentation today is entitled Collaborative Approach to Global Maternity Healthcare, and I am very delighted to welcome Nadene Brunk, CNM, the Executive Director and Founder of Midwives for Haiti. Nadene is a nurse-midwifery alumna of Frontier Nursing University. She founded Midwives for Haiti, a non-profit that educates Haitian women in prenatal care and skilled birth assistance. Ms. Brunk hopes to reduce maternal and infant mortality in Haiti, which is deemed the most dangerous place in the Western Hemisphere to give birth. After traveling to Haiti in 2003 as part of a medical team, Ms. Brunk witnessed firsthand the lack of resources and skilled care for pregnant women. Determined to provide a long-term solution, she formed a small team of volunteer midwives and medical professionals and soon returned to Haiti. At the request of a Haitian community leader, Ms. Brunk established a culturally appropriate training program for nurses, Haitian nurses in Hinche. This program is called Midwives for Haiti. It gives me great pleasure to welcome back our esteemed alumna, Nadene Brunk. Merci en pile et bienvenue.
Thank you, Jane. Thank you very much to Frontier Nurse-Midwifery School for inviting me to this premier project. Today, in looking at the title of this digital summit, Today's Nurse Midwives, Creating a Collaborative Community of Care, I want to look at a collaborative method that I think has implications for the global community. I'm entitling this The Task Shifting Midwifery Skills and an Effective Use of Resources to Decrease Maternal and Infant Mortality. And you will see as we go through how collaboration with all cadres of health workers is the key concept throughout this presentation. And my objectives for this presentation is that at the end of it, you will be able to define task shifting, which is a concept that has been around for 3 to 5 years in the global setting, that you will be able to discuss the moral imperative to task shift maternal infant interventions in the global setting, that you will be able to list the World Health Organization's recommendations for cadres of workers who have been proven to be effective in selected tasks that save lives of mothers and babies, that you'll be able to name several projects that have been used that have used task shifting and the lessons learned by these projects, and that you'll be able to describe the task shifting process in Haiti that is delivering maternal and infant interventions to thousands of women. So to begin with, I'd like for you to imagine that you are a woman who lives here in any country 19 miles from the nearest hospital. And in this case, I'm actually using a real place called Cabastor, Haiti, but this could be anywhere in the world. So you live here 19 miles from the nearest hospital, and this is your home with a dirt floor. And you have no mode of transportation unless it is a donkey, and it may not be your donkey. Your nutritional sources are limited so that you are anemic and weak and tired a great deal of your pregnancy. And the only access to pregnancy care you have is an untrained, illiterate, traditional birth attendant. In Haiti, they're called matrons. As a result of this, in your lifetime and in the lifetime of your children, there will never be a way for you to access skilled care during your pregnancy and birth. This is the reality for thousands and millions of women in this world, that in their lifetime, in your lifetime, in the life of your children, there are women we are never going to be able to reach unless there are changes made in the way we deliver that care. You as that woman will never be able to travel to where there is skilled care because you don't have the means. You will never be able to afford to move closer to skilled care. Your chances of dying due to complications of pregnancy or childbirth are 1 in 77. That's in Haiti. In other countries, it is even much higher. In the Eastern Hemisphere, there are many countries that have an even higher chance of dying in childbirth. So this is why 1 woman dies every 2 minutes in the world of complications of pregnancy and childbirth, because there are too many women who live too far to have access to skilled care. To me, this is unacceptable, and to midwives everywhere, this is unacceptable. We know there are some solutions that can bring change. We know that building and staffing more hospitals and clinics makes a difference. This costs a great deal of money. And again, there will not be hospitals and clinics close to the most rural women for years and years to come. We know that training more obstetricians makes a difference. It saves more lives, but it takes a great deal of money for that, and it takes a lot of time. We are excited about the new nurse midwifery programs that are developing in developing countries all over the world. A very, very important thing that we definitely need to support. We're also excited about more direct entry midwifery programs being developed, training more nurses and training more community health leaders and training more traditional birth attendants. All of these take money, and I want you to start thinking about the money end of things a bit. Is there an alternative to spending huge amounts of dollars building hospitals and clinics and training obstetricians and long nurse midwifery programs? Is there an alternative to having women in rural areas be totally unable to reach skilled care? Just a bit of background, according to the State of the World's Midwifery Report in 2014, there are 73 countries that carry 96% of the maternal mortality, 91% of the stillbirths, and 93% of the neonatal mortality. I'm sorry, I spelled that wrong there. But those same 73 countries have less than 42% of the world's midwives, nurses, and physicians. How do we correct that? I want to give you just a hypothetical scenario. It's been estimated that, and this is a really, really important slide to me, and I'm sorry the print is so small, but it's been estimated that 5% of all women, pregnant women, will experience life-threatening events during their pregnancy or childbirth. That's a known fact. So let's say that you have 2 million women in a country, and 5% of them are going to have life-threatening events. So that would mean 10,000 of them. And of those 10,000 women, the number of them that have access to an obstetrician, because obstetricians are rare in that country, are only 1,000. And the obstetrician can save 99% of them, or of those 1,000 people he or she have access to, 990 will live, but 9,810 of them will die. And that's because the other 9,000 don't even have access to him or her. If you're a nurse midwife, because there's more of you, it takes a little less money to educate nurse midwives. They may have access to 3,000 people. And because they may be willing to work outside of cities and and get less salary and work in more rural areas, access to them may be a little higher. So you may have 3,000 women out of those 10,000 that have access to a nurse midwife. And because they may or may not have C-section capability, or access to anesthesia, they will be able to save 70%. Again, this is all hypothetical. 70% of the 3,000 women they come into contact with. So that means 2,100 will live, and only 7,900 of the 10,000 will die. Well, let's say you have an auxiliary midwife, and this is a category that has been defined by World Health Organization, who has even less training than a nurse midwife, but because of where she lives, has access to half of the women who are at risk. Then 60% of them will be saved, equaling 3,000, and 7,000, only 7,000 will die. Or if you have a community health worker who has very limited training, but knows about risk to refer and has access to emergency transport perhaps, and lives in, and there's one in every village, so that all 10,000 women have access to this this type of worker, then because of their lack of the skills that obstetricians and midwives have, maybe they can only save 40% of the people they come in contact with, but that's 4,000 and only 6,000 people will die. So in this scenario, if you're a policymaker and you're deciding how to spend the limited dollars that are available, how many people, how many women are going to live under the policy that you choose? And in many countries, it's not an either or, but in some countries it is. If a country has limited dollars and they're putting for the next 20 years the bulk of their income or the bulk of their resources into training obstetricians, then there are going to be more women that die in the next 20 years than there would be if they were also putting funds into training midwives, nurse midwives, auxiliary midwives, and community health workers. And so in this case, it may give us a moral imperative to train where workers who have access to the women who are at most risk. So World Health Organization has thought about this, and they have a recommendation, and that is that we task shift the interventions that are known to decrease maternal infant mortality to improve access to key maternal and newborn health interventions. So this is from a publication put out in 2012 called Optimizing Health Worker Roles to Improve Access to Key Maternal and Newborn Health Interventions Through Task Shifting. And what they did is they looked at cadres of workers and decided, and through looking at what had been tried in many countries and experimenting with the effectiveness of the training, listed cadres of workers that could be used in addition to obstetricians. They described task shifting as the rational redistribution of tasks among health workforce teams. And teams is the key word. And again, it's back to the collaborative model that midwives believe in so strongly, is that whoever is chosen to receive training needs to be part of the health workforce team. What they suggest is that when feasible, healthcare tasks are shifted from higher trained health workers to less highly trained health workers in order to maximize the efficient use of the health workforce resources. And again, less people are going to die if this is implemented. The four main cadres of workers among whom tasks can be shifted are medical doctors and non-physician clinicians, nurses, and community health workers. The cadres of workers that are in the study range from, and they're not including obstetricians in these. They're saying these are alternatives. Are the advanced level associate clinician, and you can see that they that the amount of education that these people receive varies from country to country. In the publication, they give examples of where what they might be called in different countries. The associate clinician, the nurse midwife, the auxiliary nurse midwife, the auxiliary nurse, the nurse, and the midwife, someone who's just called a midwife without nursing in front of her name, the non-specialist doctor, and the lay health worker. And they, through studying the educational training that each level of these cadres receive, and then the result of whether or not they were successful and whether or not they, with the level of education they received, they were able to actually be effective in their interventions, came up with recommendations. For example, they did not recommend that a lay health worker be able to put IUDs in, but they did say that nurse midwives and auxiliary nurse midwives could put IUDs in. That's just one example. This is very small print, but just to give you an example, they built from the lay health worker on up what should be taught at each level. And they recommend, this is copied directly out of the book, they recommend that lay health workers can do the following interventions: promoting appropriate care-seeking behavior and antenatal care during pregnancy, promotion of companionship during labor, promoting sleeping under insecticide-treated nets during pregnancy, birth preparedness, skilled labor, promotion of seeking skilled labor for childbirth, teaching adequate nutrition, family planning, promoting HIV testing. So lay health workers have been proven to be effective when they were trained in doing these tasks, including the administration of misoprostol to prevent postpartum hemorrhage and providing support for women in labor in the presence of a skilled birth attendant. And this is, and then they build, the recommendations build from there. So they also recommend that with targeted monitoring and evaluation, these additional tasks be given to lay health workers. That lay health workers can distribute oral supplement type interventions such as calcium, iron, folate, and intermittent presumptive therapy for malaria for pregnant women, and vitamin A, and learning how to do initiation and maintenance of injectable contraceptive. Then they move up the ladder to nurses, auxiliary nurse midwives, associate clinicians, advanced level associate clinicians, and non-specialist doctors. And I won't go into great detail, but what they did is make recommendations, what they should be taught to do, and then what they could be taught to do if there's going to be monitoring and supervision. So they have two categories. Auxiliary midwives is one example that I chose because that is what the project in Haiti is concentrating on. And World Health Organizations recommends that they can deliver neonatal resuscitation, that they can give IV fluid for resuscitation for postpartum hemorrhage, and do internal bimanual uterine compression for postpartum hemorrhage, that they can suture, that they can give injectable contraceptive, that they can insert and remove IUDs, initiate kangaroo care, and administer antihypertensive in pregnancy, and insert and remove contraceptive implants. So this is just one example, again, of the cadres of workers that are recommended by WHO and of the competencies that they believe these cadres can be taught. Some examples: in Mozambique, 57% of major obstetric surgeries are performed by non-physicians clinicians called technicos de surgia. In Yemen, and in addition to a 3-year direct entry midwifery program, there are hundreds of traditional birth attendants receiving training and, as a result, referring appropriately to skilled care. In Cambodia, they took the traditional birth attendants and nurses and did a short training on how to do safe deliveries, put them in hospitals and clinics, and started a nurse midwifery program, and are gradually replacing those people in the hospitals and clinics with more highly skilled people, but finding that even training the illiterate and traditional birth attendants had reduced mortality. And so it was a way to start without starting out completely waiting on there be enough nurse midwives and obstetricians to take care of the need. In Mexico, where obstetricians do the majority of the births in the country, it was found that they weren't meeting the MDG goals for maternal mortality. And so they trained midwives and nurses with advanced obstetric training. And this term is more acceptable to ICM than midwives, nurses with advanced obstetric training. They trained them, and they found that they could be used to provide access to evidence-based maternity services, and were having a great deal of success in lowering maternal mortality. And after this study, it influenced national policy and led to the passage of legislation that allowed the government to hire non-physician and non-nurse professional midwives because it was seen to have that these people have access and credibility with the people in the most rural and hard to reach areas. An area where task shifting is needed is Bangladesh. Bangladesh has has millions and millions of people crammed into a very, very tiny country. In the north is where most of the hospitals are, and a tiny hospital in the south, Hope Foundation for Bangladesh Women and Children, is doing a wonderful job at correcting fistulas. They, however, have been discouraged at their efforts to get the 3-year direct entry midwives to work in the South, because all the jobs and the higher paying jobs and the better living conditions are in the North. So they are very interested in a task shifting program that would train women from each of the rural villages in the South, who would be trained especially in noting obstructed labor, which is the cause of most fistulas. Without task shifting, no skilled caregivers will work in these southern districts, and because there's only a few hospitals and the poverty level is the highest, task shifting is the only answer that these women would have, in only possibility of help that these women would have in our lifetime. So fistulas are going to continue to happen in rural areas without people who know what causes them and the ability to recognize, and it doesn't take someone necessarily who can read and write to learn that. So I'm going to move to the skilled birth project, a skilled birth attendant project in Haiti. A skilled birth attendant is defined by WHO as an accredited health professional, such as a midwife, doctor, or nurse, who's been educated and trained to proficiency in the skills that are needed to manage normal uncomplicated pregnancies, childbirth, and the postnatal period, and in the identification, management, and referral of complications in women and newborns. And as you know, WHO and ICM have come up with a list of over 30 key core abilities of a skilled birth attendant. In Haiti, there is a unique problem. The previous nurse midwifery schools that required 4 years of nursing and then 3 years of midwifery had over 60% of their graduates leave the country. So 2 new midwifery programs were developed, one to continue the 4-year nursing with an added 18 months of midwifery, and then the other was to create a 3-year direct entry program. And what we found is that graduates from the government midwifery program, because they are only producing about 40 a year, are inadequate for the need. And frequently, because they've lived and worked in Port-au-Prince for 3 to 4 years, they are unwilling to work in really rural settings for the salary that that the organizations running the clinics and hospitals can afford. So currently, the new midwifery educational programs are going to graduate between 40 and 80 women per year, but the need is for at least 2,500 skilled birth attendants in Haiti. And according to the State of World's Midwifery Report, Haiti is currently meeting about 10% of the need for skilled birth attendants. There are only just a little more than 100 obstetricians in the country, and just a little more of, and probably about double that of nurse midwives. The World's Midwifery Report also projected that if there was less attrition, if there was better access to birth control, if there were more financial benefits for skilled caregivers, if there were more skilled birth attendants educated, then Haiti would still be only able to meet 37% of the need by 2030. So something else has to happen, and we believe that it is happening. To a limited degree, not going to be the total solution, but is a solution that other countries and donors for projects who want to make a difference in maternal mortality need to consider. So Midwives for Haiti begins with students who have a diploma from a government-approved nursing school, ranging, and these nursing schools are either called in auxiliary schools or infirmier schools, and their programs range from 18 months to 4 years. So the diplomas are, having these diplomas are a prerequisite requirement. And they, at the end of the program, they get, they receive diplomas that identify them as nurses with advanced obstetric training. The program runs for 12 months, and it requires over 500 hours of classroom and 800 hours of clinical experience. So what Midwives for Haiti has done is, so far in the last 9 years, trained 95 nurses in the core abilities of a skilled birth attendant. So if you took one of those abilities, for example, the ability to administer IV antihypertensives in an eclamptic patient, the ability, they would have that. And the curriculum was built around these core abilities. The program uses Haitian nurse midwives as primary teachers, and this is in accordance with a contract that Midwives for Haiti has with MSPP, which is the government health department. Because there were key components left out of their education, it's very important that these nurse midwives, Haitian nurse midwives, have supplement have their instruction supplemented by volunteers from across the world. The graduates are delivering postpartum care to mothers and babies in hospital and clinics. There's across Haiti screening over 60,000 women for pregnancy risks in all 10 districts of Haiti. The graduates are working. In one site alone, they're attending over 200 births a month at St. Therese Hospital. At St. Damien Hospital, a similar rate of births per month. One of them, St. Therese, is a government-owned hospital, and St. Damien is a privately owned nonprofit organization. So currently, the 95 graduates, of them, there's about an 88% employment rate, and they're working in 12 birth centers, 2 clinics, and 5 hospitals in Haiti. They're providing over 1,600 prenatal visits a month in rural villages. And this is a really low estimate based on the projects that we know where they are actually going out to villages to deliver care. For example, there are 2 midwives on the island of Gonaive that are not doing births, but they are doing a mobile prenatal clinic in the mountains of La Gonaive. And they go frequently places where there are no roads. So therefore, motorcycles, this is Ebenise being loaded by her motorcycle driver to go to a remote village with her bag of iron, vitamins, folate, ampicillin, anti-worm medicine, anti-malarial medicine, and also the rapid test to test for gonorrhea, chlamydia, HIV, and syphilis, and antibiotics to treat gonorrhea and chlamydia. Another important part of the program is training these skilled birth attendants how to work with the traditional birth attendants and pull them into the health system. It is very frustrating to us to see that the funding for training matrons or training traditional birth attendants has disappeared around the world. And we know that a part of that was that the research showed that training traditional birth attendants did not seem to have an impact on maternal mortality in the country. But we believe strongly that it did not, because the emphasis was only on clean births and not on recognizing risks early and encouraging the community women to seek skilled care in the cases where risk existed. And so we have seen that training these people who live in the community with the women has been very effective in getting more referrals to the hospitals and clinics, and is really important when it comes to task shifting. These people cannot be left out, or if you do, you leave out all the women that live in their communities. So the graduates demonstrate competence in 52 skills that save the lives of mothers and babies. And if you are interested in seeing that skills birth checklist, it is on our website. They're working in every district in Haiti for NGOs and for the government in birth centers and clinics and hospitals. The government just last year hired 6 of them to work in 3 very remote villages where they could find no other midwives willing to work. They're teaching hundreds of rural women about healthy pregnancies and risk signs of risk so that they self-refer when those risks occur. The challenges that Midwives for Haiti has is doing continuing education and keeping in contact with these midwives all over the country to keep their skills up. We do have a continuing education program that meets every other month, but transportation is expensive and difficult. We would love to be able to send volunteers to these sites to work with them on keeping their skills up to date. Many of them work at sites where supplies and medications are not always available, and this is especially true for the ones who are working in the government clinics. So it's a challenge for us to keep the skilled birth attendants supplied. I think one of the frustrating things that we've had with people who ask questions about our program is that no matter how skilled you are and what kind of education you've had, you cannot be a skilled birth attendant unless you have the right supplies and medications. So putting someone, including me, including with 15 to 20 years of people with 15 to 20 years of midwifery experience, putting you in a rural area without medications, without an ambu bag, without IV supplies, and without emergency transportation would make you totally incapable of being a skilled birth attendant. And so the big challenge is, once you train someone, for example, the traditional birth attendants cannot do as they were trained unless they actually have clean razor blades and soap to wash their hands. And the same is true for the skilled birth attendants, that you can't simply put them out into the mountains without giving them adequate supplies and medications, that they won't make a difference. The other in Haiti is that all of our graduates are making barely living salaries, and that's just a part of the nursing profession in Haiti. They're all paid at nursing levels, and those salaries are, although they're very happy to get them and no one's turning down those salaries, it is something that is a challenge for Haiti, is getting those salaries up to where the level of education and time investment is rewarded. There's a general lack of respect for the profession in the government. This is improving gradually, and sustainability of funding for both salaries and supplies, medications, and teachers is always a problem. Again, just to summarize, as of mid-2015, the majority of the 95 graduates of Midwives for Haiti are working in 5 hospitals, 12 to 13 birth centers in districts all over Haiti. Most are employed by other non-government organizations, and 6 are employed by the government in rural birth centers. The mobile prenatal clinic program alone cares for more than 500 women per month, and this summer it was up to 700 women. I just saw the statistics yesterday. In 20 villages with prenatal screening that includes routine testing for sexually transmitted diseases and treatment for anemia and worms. The maternal program, this is the program that trains traditional birth attendants, has more than 100 graduates and has trained 50 matron trainers. And this is a program that was developed and is approved by the government. Based on a workload capacity and statistics from several clinics and hospitals, we estimate that the employed graduates of the Midwives for Haiti program are expected to conduct more than, I'm sorry, that sentence didn't make a whole lot of sense. The graduates of the program are expected to conduct more than 60,000 prenatal visits and attend over 9,000 births in 2015 alone. So we feel this is an example where task shifting has been used very successfully. And we believe that it has implications for where funding ought to be focused in other countries. So task shifting, to summarize, is one method of addressing the shortage of obstetricians and university-trained midwives in developing countries. It involves short-term training in specific skills that are most needed to reduce maternal mortality. It's a moral obligation to be considered by policymakers and donors. And it can save the lives of mothers and babies until there are enough obstetricians and nurse midwives to serve everyone everywhere. I know that as nurse midwives, we are very concerned about the integrity of our profession, about the respect that we deserve, about regulation and the level of competency of nurse midwives everywhere. But we also have a moral obligation to consider that we should be involved in task shifting, in using our knowledge to train other cadres of workers. And I'm very grateful that the possibility of this is happening in Haiti. Please contact me at my email, which is on our website, if you have comments or questions. Thank you very, very much for your attention today.